Most people, when I tell them what I do or, the people I see, they still kind of scratch their head. Lately, it's becoming a bigger part of the media. But essentially what I do and what all genetic counselors do is they help individuals and families better understand the impact of genetic test results, a condition that's in their family, whether it's Huntington's disease or something else, and helping work through the genetic testing process to decide, is that something that they want to consider, and what impact will that have on me, what about my partner, and what about my family. Anyone considering genetic testing for Huntington's disease, at some point in time along the process, it can be really helpful to have a genetic counselor involved. And there's no fee for genetic counseling. In Canada, genetic counseling is something that's covered by provincial health care. Often genetic counselors are located in a specific genetics clinic, either at one hospital or another in most major centers. For people who are living in smaller communities in Canada, a lot of places do outreach. So say a genetic counselor may actually come to your community if that's already set up within your province. And genetic counseling and genetic testing both are, like I said, covered by provincial health care. It's something that if someone's interested in learning more about what genetic counselors are in their city, they can look that up on the Canadian Association of Genetic Counselors has a website where it'll list all of the clinics in Canada, all of their members. So that's one way to get in touch with someone close to you.
If someone was looking to get genetic testing done, do they have to go through a counselor?
That's a good question. It can happen a couple of different ways, and it really, in part, depends on what's the particular question you're trying to ask. So genetic testing for Huntington's disease is really can happen in two ways. The first is what we call diagnostic testing. So say, for example, someone is exhibiting signs and they go see their neurologist, and that neurologist feels that, yes, I think that there are enough clinical signs and symptoms here to make that diagnosis of Huntington's disease, regardless of the genetic test result. Then a neurologist may order, and often does order, the genetic test to confirm that diagnosis in an individual. Sometimes along the way, if a neurologist, at least I can speak in the Maritimes how it works for us, if a neurologist sees an individual and they might have some really subtle signs and symptoms, not yet enough to make a clinical diagnosis, sometimes they'll refer them to us and we'll become a part of the testing process as that is, Huntington's is one of the things that they're considering in their differential. So sometimes genetics will be involved then. For predictive testing, which is testing of a healthy person with no symptoms, they have a family history of Huntington's, that always must include a genetic counselor. So in the Maritimes, no other healthcare provider can order a predictive test for Huntington's until someone's been seen through our service. And that's because, as maybe some of you know, there's going through the predictive testing process can take quite a bit of time and a number of months. So that's where a genetic counselor is the person who, will ultimately order the test once someone's been seen.
You mentioned that sometimes the process takes a long time. Why is that? Why does it take so long?
Yeah, and well, it's hard. And so the genetic testing itself, if we're just looking at the blood work, the turnaround time for that can vary a little bit. So from lab to lab across Canada, across the states, or across the world even. So sometimes in a lab, you might get the results might be completed by the technical staff in 7 to 10 days. Sometimes it can take weeks to come back though. So it has to go through the testing process, be reported by the lab, and then be sent out to the genetics clinic, say, who ordered that test. So that the logistics of that blood work can take a little bit of time. But you have to add on top of that the genetic counseling process or the predictive testing process. And that timeline can vary a little bit, but generally speaking, from province to province, an individual would meet with a genetic counselor first, and in a number of weeks after that, meet again for a second appointment. Then after that appointment is when blood collection would happen. So then you need to add on the time it takes to actually do the test, and then meet again for results. So it can take a number of months to work through that process, but And some people, when they sit down with me at first and I let them know what that is, they are a little bit frustrated and they, well, you know, I know already I want the test. Why can't you just do it right away? I always let people know that I've been doing it long enough that I can say, at the end of it all, you'll understand why it's important to go through the process, even though you might not want to meet with me this many times. And then at the end of it, people often do say, okay, I get it now. It takes some time to work through all the different scenarios and you know, help look at things from different angles to decide if that's something testing you want to do.
Yeah, I can understand that from a young person's perspective, because the decision to undergo testing is such a life-altering decision that...
Big one.
Yeah, I guess you guys want to make sure that we're doing it for the right reasons as well, right?
And yeah, and then in part, like, that's part of what my job is to be another station of support. Some people, you know, they don't necessarily want to involve their family members or their friends, and it can be helpful to establish some sort of relationship that, you know, at least you can be somewhat familiar with me and the process moving forward, that, you know, it's just another avenue of support, really.
Good. Okay. And you mentioned this maybe already, but who can make that referral for someone like myself to see a genetic counselor or go to a genetics clinic? Do you have to go through your doctor, I guess? Is that the protocol?
So I can't speak for every province, just because I'm not sure for each, you know, Ministry of Health, if there's limitations that I'm just not familiar with from province to province. But speaking from the Maritime perspective, it's because we're considered really you know, a specialty service in healthcare. It's ideal to have a referral from a family physician. And generally speaking, when I'm speaking with someone going through predictive testing, it is helpful to have the family doctor involved, because of course, should someone find out that they did inherit an expansion in the HD gene, that family doctor is going to be that you know, that point at which you know, helps make referrals to other specialists and those sorts of things. In the Maritimes, we do have a bit of a, you know, in some places, a bit of a shortage of family doctors. So it's not uncommon for someone to say, you know, Megan, I lost my family doctor 2 years ago. What do I do? And then we, you know, a nurse practitioner can be involved and help make that referral. If by chance someone's family doctor didn't want to refer them to genetics, then there are circumstances where we will take a self-referral, where someone can, you know, call the genetics clinic and say, whatever, you know, it could be a number of reasons, but they can't get a referral. Of course, I'm willing to, you know, to take that self-referral and facilitate them being seen. So ideal world, referred by a family doctor in the Maritimes, but it's not the be-all, end-all.
Good to know. You also talked a little bit about the predictive testing, so the actual getting the results, a healthy individual, I guess, getting genetic results for a genetic disease. Can you maybe expand on that a little bit and maybe talk about a little bit more in depth about the CAG repeats that you mentioned?
Sure. I guess in terms of I'll maybe on the predictive testing process a little bit, which I didn't quite elaborate on what that looks like for some people who don't know, and then I'll lead in to talk about the different genetic test results if that helps. So the predictive testing process is one that's been established for quite a long time in the world of adult onset genetic conditions. Huntington's disease has really been the template for how a lot of other you know, testing has taken place. In my mind, Huntington's it's really the epitome of genetic counseling, because that genetic test can be is, for lack of a better word, more concrete than some other things we deal with. In the first appointment meeting with a genetic counselor, again, this is how we do it in the Maritimes. So if you meet with me, I like to call it the information gathering and giving. It's an opportunity for me every person is different, every family is different, and I want to know more about where you're coming from. And also a chance for a person to ask me all those different questions that they might have. In that first appointment, that's where I talk a lot about the genetics. So some people come from very different backgrounds or accessibility to information. Some people are Googlers. I just joined Twitter a month ago, so I mean, you know, there's all different modes of communication that people use. But it is an opportunity to talk about the genetics of Huntington's a little bit more. I always use visual aids when I'm in a genetic counseling session. I don't have that here, so I'll use my best to describe our genetics of the things that we can't even see it with the naked eye. So we all have the same genes. You and I have the exact same genes, and it's just small changes in our genes that make us different people. Perhaps someone taller, shorter, brown eyes, blue eyes, whatever the case may be. Our genes, every gene has a specific function, and in the world of genetics today, we're in a place where we know of the function of a lot of our genes, not all of them by any stretch, but a lot of them. And every human being has 2 copies of the HD gene. And like I alluded to before, there's a region of the HD gene that if it's bigger than it should be, that's when someone can go on to develop signs and symptoms of Huntington's. And that's what that CAG repeat is. The letters CAG are part of our DNA or our genetic code. Everything about us is determined by 4 letters, A, C, G, and T. That's our genetic code. Different sequences determine what different genes do. Okay? The CAG repeat, generally speaking, the average person might have 17 to 18 of those CAG repeats in each of their HD genes. Again, one they inherit from their mom, one they inherit from their dad. In genetic testing, what we call a normal or a gene negative result, you can hear different terms for that, is when someone has 26 or less of these CAG repeats in both copies of their HD gene. This person will never go on to develop symptoms of Huntington's disease, nor can they pass it on to their children. Okay, so that's what a normal or gene negative result is. There's an intermediate zone, or what they call intermediate alleles. Some people might have heard the term, it's a gray zone, and there's, again, different terms for that. That result is when someone in one copy of their HD gene has a repeat size of 27 to 35. The other gene copy is normal. So that's what the genetic testing will look at for that. When someone has 27 to 35 copies of that CAG repeat in one copy of their HD gene, that person won't go on to develop signs and symptoms of Huntington's, but there is a risk to pass on a bigger expansion to their children. And that's a rare phenomenon. It's not that it always happens or anything like that. There are a number of other factors that can play into that actually occurring. The next one is a repeat size of 36 to 39, a CAG repeat, and that's what they call a reduced penetrance. And that word means, penetrance is the word that they use in genetics to highlight the number of people that will develop clinical signs of a condition if they have a change in their genes. Okay, that's the fancy word in genetics to describe what that is. Reduced just means that not everyone will go on to develop signs of Huntington's disease if they have a repeat size of 36 to 39. Some people do. There are lots of families that someone may be diagnosed at 80 years of age, and that sometimes is a clue for me that I wonder if this is a reduced penetrance, because it's much older than you would typically see. Okay? The last category, gene positive, is when someone has 40 or more repeats in one copy of their HD gene, and the other gene copy is normal. Okay? That person at some point in time will go on to develop symptoms of Huntington's disease. And those are the 4 different areas that we work through in terms of understanding what the testing is looked for, what it can tell us. The areas in between, the intermediate alleles and the reduced penetrance, can cause a lot of confusion for families, but also be really difficult to wrap your head around in terms of, what am I going to do with this information? Is there anything, would I change anything in my life? Would I take any action? And that's a harder one to understand for sure. The second time that I meet with someone in the second session, we review all that again as needed, and sometimes people go away to think about it a little bit more. And then after that appointment, if they want their blood collected, that's what we do. The third appointment when I meet with people is for results. And that's when we review what the results of the genetic test is. And that's an opportunity to meet a person again and to, talk about what that result may mean. Sometimes it's a quick appointment in and out because that's not the time when you want to talk about anything in more detail, really. So then we can always set up a fourth appointment as needed. So that's really kind of encompassing the predictive testing process, but also the focus more of what we talk about with regards to the genetics.
Cool. Okay. You talk about like the gray areas. Is that have anything to do with, is people thinking HD could skip a generation or sort of spontaneously show up in a family?
Yep, and that's exactly it. And it's something that has evolved over time, and we as healthcare providers have learned a lot more about what that means. Often, a lot of people do ask me, does HD skip a generation? And it doesn't. When there's an individual diagnosed with Huntington's in a family, and it looks sporadic, there's no other family history, we don't understand, we know a lot about someone's family history, but we can't see where it could have come from. It's often the case where a parent may have, more often a father may have an intermediate allele or reduced penetrance allele where they don't show any signs and symptoms. But then when passed on to the next generation, that expansion can get bigger. So someone will show signs at an earlier age, and it may become more apparent. Sometimes people use the word anticipation, and that's a word in genetics that we use to describe a condition that can get, the age of onset can get younger from one generation to the next, and the signs and symptoms, like what I mean is the signs and symptoms showing up at an earlier age. And that's where, a sporadic case of Huntington's, how it might be explained, if that makes sense.
Yeah. So what if the case is that, say your parents were tested for Huntington's disease and they were gene negative or had a negative result? Is there a way that their children could have Huntington's then?
So that's a great question. And essentially, we have 2 copies of every gene, like I said. And if someone has 2 normal copies of the HD gene, and we know that in their extended family history, there's Huntington's disease. Mm-hmm. Person right here has tested negative. This person can only pass on 1 gene copy or the other to their child, because it's a 50-50 chance, even for that gene negative it really doesn't matter which one you pass on. Right. The reason I'm kind of highlighting that is that you can never say never. So in the general population, it's possible for people to have these intermediate alleles, that 27 to 35 range, but of course they would never know because there's never any signs and symptoms, no clinical signs of anything, because that person will never go on to develop it. So that can come through the generations in a family and be silent, essentially. So is there that very small possibility that someone could actually inherit one of these intermediate alleles from the other side of the family, not affected with Huntington's? Yes. In genetics, I'm always careful to never say never. The negative result in a parent or in a person who has a family history obviously is fantastic news. That little tiny, risk or chance of inheriting it from the other side of the family is really very, very small. But sometimes the reason it's important to highlight is that when you're going through the genetic test results options, it's important to at least say there's sometimes you can get a surprise result and have something show up from the other side of the family that doesn't have any clinical signs or symptoms.
I have a question about juvenile Huntington's disease. The CAG repeats in that specific case, are they like extraordinarily long? Like, are they much more repeated then too?
Yep, that's a great question, and yes, they are. If in an individual, like juvenile Huntington's is I guess to define that first, is Huntington's disease diagnosed, I forget the upper limit, I think it's before the age of 20 or maybe 21, so in a very young person, so definitely out of the ordinary. If you look in the medical literature and to look at the variation in the repeat sizes, there's a correlation, an inverse correlation between the number of repeat sizes, so as that gets bigger, the age of onset gets lower. Okay. So say, for example, if someone had a repeat size, which is rare, of, say 200, which is huge, then the age of onset can be really, really quite young. It's very difficult because, I mean, a very small percentage of Huntington's is considered the juvenile type. And when a child or a teenager or anything like that is exhibiting certain signs and symptoms, Huntington's, of course, is not the first thing that would be on the top of a doctor's, differential, really, because it's pretty rare. You think of all the other potential things, environmental, an imbalance in certain vitamins and minerals, all those sorts of things. But yes, it is when that CAG repeat size is much bigger than you would typically expect.
Just another question about the CAG repeats. If you inherited that gene, the HD gene, from one of your parents, and that number of repeats was the exact same, could you expect that the onset of that disease would be about the same as your parent experienced?
That's a great question, and it's one a lot of people ask, because a lot of people really want to know, well, how much can you predict with predictive testing? You call it that, but what are we actually predicting? The really hard thing with the genetic testing is that we'll use using the black and white example of a parent who has a repeat size greater than 40, okay? So if a person goes on to develop the exact same repeat size, say it is 41, that only tells us that at some point in time, a person will develop signs and symptoms. But Huntington's is extremely variable. Even within one family with the exact same repeat sizes, or if you compare families with the same repeat size, the age of onset is quite variable. The problem is that the repeat size can give you an idea, and it does play a factor in terms of at what age a person might develop symptoms. But at the same time, there are so many other genetic factors, environmental factors, things that we don't even know about that you can't pinpoint that can affect it. So the hard thing sometimes for some people is thinking, okay, well, yes, at some point I will develop signs and symptoms, but I don't know when those will happen. I don't know what they're going to look like, because it doesn't always run true in a family with regards to what type of symptoms someone might show first. So you can only talk in very general terms, and that can be one of the hard things for people to wrap their head around. So although we call it predictive testing, there's also things about Huntington's that we can't predict.
Just wondering, because I know as a young person with a familial history of HD, it's one of those things that you consider when you go through genetic testing, is, you see your parent going through it and you think, that could be you at that same time and place in your life.
It's interesting, and one thing I've learned from families through the years that I've done this is that it's very, very common for families to have a particular age that they sort of hang their hat on. Often it might be even an aunt or an uncle. It could be their parent or a sibling. The age at which, and they use so many different terms to describe that period of time where things, were perhaps like at their worst, at their most difficult, for lack of better words. And once someone approaches that age, it can be a very, very difficult time in someone's, personal journey through having a family history of Huntington's. Sometimes people come to me before that age that they have in their head, and sometimes people come to me after that. And that can often make someone feel very differently about, or their gut feeling as to whether they might have inherited the expansion or whether they might not have. So it's important to identify those sorts of predetermined thought process about your family history when you're going through the predictive testing process, for sure.
Thanks. Another aspect that is pretty relevant to YPAD and young people affected by HD is the whole idea of genetic discrimination surrounding a hereditary disease like HD. Can you sort of outline some of the negative consequences of genetic testing in this regard?
Yeah, that's a huge, it's a hot topic issue, and it comes up in my clinical practice even outside the world of Huntington's. And more and more in the media, and it's different countries are at really different places with regards to how they're truly incorporating genetic information into things like a personal health record, electronic medical record, insurance policies, the list goes on. It's at a conference I was recently at, there were many talks from people all across North America about this type of issue. In Canada itself, Canada doesn't yet have a way to protect against genetic discrimination, different from where the States is right now. I know through my chat with Bev a little bit earlier today, you know, she's really even more on top of that than I am for sure. I try my best to keep in the loop, but it's hard. She was telling me, and I might get the acronym wrong, but the CCGF, Leah, you might know that one, is a place to go to get more information on genetic discrimination and those sorts of things. With regards to negative consequences about insurance, that's a question we get all the time, and we ask people about that a lot. Do they have any, you know, where do they work, and what type of insurance do they have through their employer already, and those sorts of things. In an ideal world, for young people, the message that is helpful and one that we're trying to get forward is that if you have questions about your insurance, then the first step isn't to get a referral to genetics from your family doctor, because then that referral is on your permanent health record, and your family doctor sends it to us, and that's a great way to get in touch with us and ask questions, of course. But really the first step should be, if insurance has crossed your mind and you want to put into place either life insurance, you're getting a new mortgage, you know, disability insurance, critical care, all the permutations of what that looks like, that should be the first question before you ask a healthcare provider about that. In the Maritimes, when we chatted about this a couple of months ago, you know, one thing is, if there's certain questions, you could pick up the phone and call our department as a way to help get in touch with people. Ask the local person or your employer who's involved with your insurance plan as a way to get your ducks in a row, for lack of a better term. I think that's really important because once a person has asked their family doctor for a referral to genetics and they've come to see me, regardless of whether they've had genetic testing or not, even if they haven't had their blood collected, that information is there that you've gone to talk to a healthcare provider about your family history of Huntington's. Insurance forms are written in lots of different ways, and every company, I joke a lot of the time, you know, you sort of need a degree in rocket science to understand a lot of them. We're very fortunate here in the Maritimes to have a colleague of ours who was giving a talk downstairs, and I don't know if everyone else could hear that or not, but he's helped me understand a lot more and has talked to a lot of our families about what their options are, different types of products that are out there where a company doesn't ask a million questions about someone's health history, different ways to get life insurance, or does someone invest in, you know, put their money in a tax-free savings account as a way to save for the future. Some of those negative consequences, it's hard because I've seen people before where, you know, they might have put something down on an insurance form and then the company says, well, wait a second, you've never had testing for Huntington's. So once you go through that, then we can, you know, your premiums might be X, Y, or Z, or we won't exclude you for this. So it has happened where we've been asked that question and someone's come to see us more so because of what they're trying to, you know, the financial burden of what that insurance cost may be. And that's a really hard position to be in. All that to say, it's a complicated issue, one that I definitely, I'm not an insurance expert. I try to learn enough about it to be able to help people. The bottom line is that instead of going directly to a healthcare provider to ask for a referral first, the insurance piece should be the first question, essentially. Get those ducks in a row first, and then make your way through the process. But that's something, if you called your local genetic center without a referral, I hope, you know, hopefully there'd be someone there to be able to help at least guide you if there were more specific questions. Long-winded answer to a very complicated
I know it is very complicated, and I know that Bev Heim-Myers is really involved in the genetic discrimination front too. So if other people out there do have questions, she's a good resource to talk to. And I think the government is finally hearing some of the voices on that. And there is a bill in the Senate right now. And I know there was a mention about eliminating genetic discrimination in the throne speech a couple weeks ago too. So that's exciting. Another question I do have for you is in regards to family planning and that sort of thing. So can you maybe go into a little bit about reproductive decision making and that topic a little bit?
Yeah, it's very interesting. In my clinical practice, I see people in kind of two different silos sometimes. I see people who have completed their families. They might be either, well into their career, maybe even close to retirement, those sorts of things. The reproductive side is a bit of a moot point for them because they've already completed their families. They're trying to gather that information often for their children or to plan, am I going to retire earlier? Am I going to go on that trip sooner rather than later? The other branch of people I see are people, who are quite young, maybe, even late teens, early 20s, so say, 19 to 25, where they've had a family, known about their family history of Huntington's for a long time. They've grown up as that being part of their life. For them, the questions about family planning and the reproductive decision making, sometimes they want to know information before deciding exactly how they're going to have their family, if someone does want children, that is. I always say that deciding to have children is a huge decision to make, regardless of what your family history is of anything under the sun, because that's a big choice in itself. Then trying to make that decision with the added factor of having a family history of something like Huntington's can take a little while longer for young people to work through. Well, how am I going to make that decision? I'm not ready to have kids yet, maybe 20, but someday I do. So do I want to get this information now to help me make that decision down the road? And that's a big question. A genetic counselor is definitely a person to help work through some of those options. Sometimes when someone expresses to me that they would choose not to have their own biologic children if they did have a gene expansion, then we talk about, well, what are some of the other ways that a person or a couple can have a family? We talk about things like adoption, either from within our own province, or sometimes people choose to adopt internationally. We've had some people go down that road. Some people also want to talk about pre-implantation genetic diagnosis. That's a process. So pre-implantation is exactly how it sounds, before implantation of the embryo. Genetic diagnosis means genetic testing before the embryos are implanted back into the female, so that they do the genetic testing to implant unaffected, so that there isn't a risk to pass on the expansion. So there are some people who do explore that option, and the accessibility of that can vary from province to province for sure, because we see people from Nova Scotia, New Brunswick, and PEI. It's slightly different. Often a couple would have to go to a larger center to explore that option, or the full scope of what that option is. And then some people express to me that they want to know to plan, but if they had an expansion or not, they wouldn't change how they would want to have a family. And it's a very, very personal choice. As a genetic counselor, it's always important for people to know that I'm here to provide information to support whatever decision an individual or couple want to make, and I'll help get you, through that process, whatever it is. There's no right or wrong answer for every person, because every person in every situation is entirely different.
So if somebody wanted to explore those options like PGD or whatever, is something a genetic counselor could help you or be referred to, or do you have to go through your family doctor?
Well, it's helpful if you have questions specifically about PGD or the pre-implantation genetic diagnosis. I would definitely suggest making a referral to your genetics department. And then different genetic centers have different connections with centers that do this type of assisted reproductive technologies. So again, not being able to speak for every city or every center, a genetic counselor in your area can help you figure out, well, what would work for you. For in the Maritimes, for example, couples that we meet with will often travel to another city. So for example, Montreal, Toronto, some even to go to the States for the full scope of the process itself. It's very expensive, and that's the hard thing for people to wrap their heads around of how much money it can cost. So planning for that is also something people like some time to do. But a genetic counselor or a genetic center is a great first stepping point to start to ask some of those questions.
Okay. Thank you, Megan. That's sort of the questions that we had for you during the initial period. But I do have a couple more questions here that Devin has just given to me from those in the community. If you're okay with me asking those now?
That's to answer.
Okay. The first one is, what is the most stressful stage of the whole testing process for that person at risk, would you say?
From what I understand from people I've seen, it's that moment that someone has their blood collected. When they have blood collected to the time we meet for results can be extremely difficult because a person, as much as they try to just put it to the back of their mind and think about other things, it is completely at the forefront, just waiting and anticipating. Then for a lot of what people tell me is that then the moment when they get called and say, you know, hi, I'd like to book you in for your follow-up to see Megan again, then people know that, okay, well, geez, that means she must have my results. Even though I tell people, you know, they come in a sealed envelope and it's not opened, you can still choose not to come in to get them. That moment where you realize that they're ready can be really difficult. The other thing is the results day itself. Some people don't, we always work through that day. I'm kind of a planner, and I like to help people plan what they're going to do that day because you can't fully anticipate what your emotions will be. I often tell people, so say if we're meeting at 11 o'clock in the morning, but you usually get up at 6 a.m. Well, what are you going to do for those few hours before we end up meeting? It's important to think about them. Sometimes people don't realize that in the few hours before their appointment can be the most difficult, and the clock can kind of tick by. I like to help people think of something that they're going to do to stay active or busy before our appointment, and then always plan something for right after. Having your support person there, planning what you want to do, whether it's go out to your favorite restaurant, go for a drive. You know, I've had people say, I'm going to go get an ice cream to I'm going to go buy a Corvette. So I don't suggest the more expensive option, but I've had everything under the sun. So it's really, it's the blood collection to the time we sit down and meet again, and all the kind of mini stages in between that can be the most difficult.
Okay, thank you. You may have touched on this a little bit, but maybe you can just go into it a little bit further. This is another question from the community. What is the follow-up process once you receive the results? How long would you maybe follow somebody?
Yeah, so that can vary a little bit, and it's partly dependent by the person coming through the door. So for example, if someone has a good news result and we know that they don't have an expansion in the HD gene, I always call them again anyway in a couple of weeks' time just to touch base, because some people, you know, even though I hand them the letter before they leave the office, sometimes they say, did you really say that? Is there anything I'm missing here? Did you leave anything out? So I always will touch base with someone with the caveat, of course, at any point down the road, someone can always easily reach me by phone to touch base. When we find out that someone does have an expansion in the HD gene, I always let someone know before results that that appointment is still guided by that person. I don't take offense to someone if they say, listen, I don't want to talk about this right now. Can we just, leave this and do this another time. Of course, that's more than fine. Some people, even after you talk about the results, they want to spend that next hour talking about the plan. Well, where do we go from here? Do you refer me to neurology? Who do I see? So all the same information will get out, but at a time that's right for that individual. For my follow-up, I always will touch base with people as many times as needed, depending on the particular situation. Often it's by telephone. Some people prefer to email me. Sometimes they want to set up a video conference because we use a ton of video conferencing in the Maritimes because our families are all over the place. I don't want someone to have to drive down from Bathurst, New Brunswick to Halifax, so I use this sort of technology to help connect with my patients in an in-person way. If someone is not yet connected with neurology, there are a few neurologists, in the Maritimes, and also in Halifax. There's a multidisciplinary Huntington's group, and they're fantastic. And so, if we need to make a referral to them, if they haven't already been connected, I'll go ahead and do that. I know the nurse that works in that clinic is there in the audience in Halifax, and she's been a wonderful resource for us for making sure families are connected. And of course, Barb Horner, the social worker for Nova Scotia and PEI. So I kind of connect people as needed. Sometimes a family doctor might call to ask some questions and about the physician's involvement. And so we use, of course, the HD Society books that are wonderful to help guide them. So all in all, it's really driven by what that person needs. What does that family need? And, we're just here to help at every step along the way. Sometimes my involvement with someone may be a lot shorter, but there are people that I talk to for years after, I see them through their testing process as questions come up for their family or for them.
Okay, thank you. Another question here from Sherry in London. Do you recommend testing for people ages 18 to 20? And what are the age regulations in other countries?
That's a good question. I guess I'm not entirely sure on the age regulations in other countries and what exactly that age cutoff is. I know that we consider, adult being 18 or older, essentially. And when I see a referral coming in on someone who's 18, 19, 20 years old, I will always, of course, we always accept those referrals and meet with someone to explore what their questions are. Because sometimes people of that age group aren't actually looking for testing. They want to talk to you a little bit more about what it means for them, to understand a little bit more. And maybe they want an external person to their family to help answer some of those questions. And if I'm meeting with someone of that age and they really want testing themselves, then I always explore more what's their family circumstance and what's driving them to want to know this question at this point in time in their life. There are some 20-year-olds that I've met that are mature beyond their years. They've lived with Huntington's in their family since they were a very small child, and for them it's sometimes a very different question because they know exactly why they're asking the question, even at the age of 20. Other times it's newer to that person, and the referral to genetics can be more, oh my goodness, I've heard about this and I don't know what it is. What do I do from here? So I do take a lot more time to, a person of 18 to 20 has very different questions than a person who's 50 or 52 years old, for example. I don't know, there's not a right or a wrong answer in terms of a should or a shouldn't. It's very individual to the circumstance of that person.
What about for younger kids, I guess, like people under 18? What do you recommend for them if they wanted to get testing?
Yeah, and that's a whole other ballgame altogether.
Oh.
There are basically in the world of genetics, this isn't just me that feels this way. Genetic testing for what we call adult onset conditions, so something that doesn't affect someone in childhood, genetic testing for those is not recommended until someone is at an age where they can make that choice for themselves. Okay? There's nothing someone that's 14 years old, needs to be doing or should be doing, and they're not at an age where they can really likely make that decision for themselves. The genetics, the predictive testing process is interesting because once the gene for Huntington's was discovered, everyone thought, well, of course people are going to be knocking on the doors of all the genetic genetics clinics and wanting that testing. Well, it's actually not the case. There's different out there, but say anywhere from 10 to 20%, 25% of individuals who are at risk of Huntington's actually ever seek predictive testing. And because there's nothing you can or should do or would do in a child, it's really important for someone to be able to make that decision for themselves. And that's not just for Huntington's. Genetic testing of any adult onset condition is not recommended, and that's supported by a lot of genetics guidelines throughout the world.
So if someone under 18 wanted to get genetic testing, you could still speak to a genetic counselor on that fact?
Yeah, I've had people referred to me who are in their teenage years, and genetic testing isn't going to happen, but I'm more than happy to meet with them because one thing that some people do express concern about is parents want to know, well, how do I talk about Huntington's to my kids? Is there an age at which you bring it up? Do you introduce it? What's the right age to tell someone? Especially in the teenage years, people can start to have a lot more questions. And then I always offer to people that I'm more than happy to meet with anyone at any age to, facilitate talking to a child about that. Parents know their children way better than I do, but if there is something I can ever do, I'm always more than happy to meet with them.
Good. Another question that was texted to Devin from the community. Somebody wanted to know who is present when I get my results. So are you there by yourself to give the results, or I think that's what they're alluding to.
Okay, yep. I guess that could vary from clinic to clinic across Canada, just because there are some groups that work, maybe even in the same office as people in neurology. So it kind of varies a little bit. But generally speaking, for our service, it would be myself or my other colleague Jill, who works as a genetic counselor at our clinic too, a geneticist, so a physician who has a specialty in genetics, the person themselves who's having the testing, and then the support person that they've brought with them. If they brought someone through that process, they can bring them, of course, to that result session. It can be that sometimes, someone's family physician might be present, or Barb as a social worker, or it can vary a little bit. Generally speaking, genetic counselor, the geneticist, and the person who's had their blood collected, and whoever they choose to bring.
One more question here. What should you do if you feel like your genetic counselor didn't handle the process correctly? This person, I guess, felt pretty alone during the processing and the testing. Are there follow-up options for them?
Oh, well, I mean, I guess firstly, I'm really sorry to hear that person felt that way going through the process. One thing, it's hard to know exactly where to go. I feel like if someone felt, particularly alone, or it's hard, like every individual relationship between a genetic counselor and an individual going through testing is going to be different. So as I mentioned, there's myself and my colleague Jill who work in our clinic. And so we're two different people as well. I hope that someone going through the process with one of us, it's hard to say, listen, I'm not really sure if this is working for me. Do you have a colleague that maybe I could see or something like that? It's very difficult for people to do. Someone really felt that there was, say, even more harm that came from going through that process, I would recommend that they do talk to the genetics clinic involved, even perhaps the manager or something like that. Is there another genetic counselor that they could potentially be involved with that maybe they, might have more of a connection with? If for whatever reason they're finding that that's not an avenue to go down, then the social worker that's involved with the HD Society in every province, they're always a wonderful resource to help, connect people. So there's a number of different ways to go, and, it's hard to say exactly without knowing the specifics. I do feel, badly that someone felt that way going through the process, and I hope that one of those avenues might be a way that they could reconnect with either even another person in their genetics clinic, a social worker, or someone else.
And I think you make a good point about maybe even connecting with the HSC to get connected with a social worker or, you know, the YPAD chapter or
exactly. There are many
like
resources out there, and it can be difficult and daunting to know exactly where to go as well.
Yeah. Good. Well, thank you very much, Meghan. I think you've done a wonderful job at enlightening us on the process of genetic testing and genetic discrimination and the many issues and technical side of the whole testing process. So
thanks for having me here. It's great.
Good, and thank you for taking the time out of your Saturday to join us. We are really appreciative. Thank you.
No problem at all.
Do you have anything else you want to say before we move along, or?
No, I don't think so. That's great. And of course, if anyone has questions beyond today, I know some things were emailed to me before that were pretty big questions. I'm always more than happy to connect with anyone. And if someone has questions on how to reach a genetics center near them, I can find someone in their local area. So I'm pretty easy to find if you need to find someone in Halifax.
Okay. And I know Devin Bonner at the HSC does have your contact information, so if anybody does want to get in touch with Meghan, they can get in touch with him and he'll connect them.
Yeah. Okay.
Okay, thanks again, Meghan.
Okay.
At this time, too, we're going to ask Bev to join in. I think she's waiting on standby.
Where do I hit?
Oh.
Here.
We did actually have one more.
I'm on, I think.
Hi, Bev.
Hi there. This is a little new for us, so getting it down to wonderful timing is taking a moment. So, Meghan, thank you very much. That was incredibly interesting, and thank you very much for sharing that information.
Yeah, no problem at all.
I think everybody will benefit from that. Thank you. And Leah, what a great commentator you are, and asking questions. Good job.
Well, we do have one more question, actually, Bev.
Okay, I'm just going to change my camera a little bit. There we go.
Okay, that came in from the community, and we asked you to join in because it has a little bit more to do with the genetic discrimination. And since you are the chair of the Canadian Coalition for Genetic Fairness, someone in the community was asking, what exactly are we doing about genetic discrimination in Canada today?
Great question. So it's good that this community, well, good and bad, this community has experienced genetic discrimination, and Canada, as we know, or most people know, is the only G8 country that does not protect genetic characteristics yet. So genetic discrimination has to be tackled at both levels, both the federal and provincial level. So at the federal level, and you mentioned this earlier, Leah, that preventing genetic discrimination was covered in the speech to the throne. That's very exciting. It's the first time that it's been addressed. So the government, we commend the government for listening to the voices of the people, and this opens the door for it moving forward. The day after it was presented, Senator Cowan presented in the Senate, as you mentioned also, Leah, Bill S-201. It's a genetic non-discrimination bill. It's the most comprehensive bill we've had to date. That's incredibly exciting at the federal level, and I'm working with 2 provinces right now to also move forward to make those provinces genetic fair. It's exciting, and everybody who is contributing and listening and participating in this call, please give your senators a call, give your MPs a call, give your MPPs a call, and let them know that you support genetic fairness in Canada, and we will make it happen. And as a community, we will make it happen, and as a coalition, the Coalition for Genetic Fairness, we will make it happen. They're listening. The government is listening. Our decision makers are listening, and it will happen. So everybody support it, and let's make it happen.
Yeah, that is very exciting. And I know, and for the case of YPAD too, we did develop a draft letter that people can print off and sign their name to and mail to their local member of parliament. Just to, again, to show your support for the genetic fairness moving forward. So that is available too.
And we also have one on the website.
Good. Yeah. Awesome.
Yeah, thanks, Leah. That was great.
No problem.
So,
thank you.
thanks to everybody for watching, and right now we're going to take a 5-minute break, and then we'll return for part 2 of our fall symposium. Thanks very much. We'll talk to you soon.